Hi all. Today's topic of discussion is going to be ABG interpretation, and this is in continuation with our ventilation series. So why do we need to measure pH? So an optimal pH is at which your body systems function to the best efficiency. Your enzymes work well, your receptors work well, and that's why you need the pH to be normal. What is the normal pH? pH is somewhere normal between 7.35 to 7.45. Even a 7.34 is considered acidosis and 7.46 is considered as alkalosis. So you need precise values to exist in your body to maintain this homeostasis. So what is normal? Let's say all the normal values. Disclaimer, if you hear some background cracker sound, it's Diwali, happy Diwali. So forgive me for that. So normal pH is somewhere between 7.35 to 7.45. Normal oxygen concentration in arteries are more than 80 millimeter of mercury, somewhere between 80 to 100 millimeter of mercury. This PaO2 is usually around 5 times that of the inspired oxygen concentration. Okay, so this is a thumb rule that you can follow. PaCO2 is 35 to 45. Again, another thumb rule that you can see is the last 2 digits of your pH will correspond to that of the carbon dioxide concentration. Bicarbonate concentration is between 22 to 26 millimeter of mercury, and anion gap normal is around 12 to 16. So what are acids and what are bases? So acid is anything that has a hydrogen ion and alkali is anything that has a bicarbonate. So I will not be discussing in the traditional sense where you say going in the same direction and going in the opposite direction, because personally that is more confusing for me. This sort of understanding is easier for me, so that is how I am going to teach you guys. So anything that increases your hydrogen ion concentration results in acidosis. Anything that decreases the alkali results in acidosis. Correct? Simple, isn't it so? Anything that increases acid should cause acidosis. Anything that decreases acid should cause alkalosis. Why have I put this carbon dioxide in bracket? See, any carbon dioxide increase is generally associated with acidosis. The reason being this: carbon dioxide combines with water resulting in carbonic acid. Okay, so this is again, this can dissociate into bicarbonate and hydrogen, but the thing is this is an acid. Okay, and so increase in carbon dioxide will cause increase in this acid, ultimately resulting in acidosis. So I hope this is clear. So how do you analyze your standard ABG? First of all, is the arterial blood gas consistent? Is the pH and hydrogen ion concentration correlating with each other? How do you do that? You do that with the help of Henderson-Hasselbalch's equation. Henderson-Hasselbalch's equation states this: hydrogen ion concentration is equal to 24 into your PaCO2 by bicarbonate concentration. Okay. So in your ABG you will have your carbon dioxide, you will have your bicarbonate value, right? If you put that into the equation and you get a hydrogen ion concentration, you compare it with the standard table. This standard table will be found in any textbooks, any ICU textbook, emergency medicine textbook. Okay. So if the hydrogen concentration is not corresponding with the pH value in your ABG strip, then the ABG is inconsistent and you may not be able to interpret that ABG because you are not sure if it was drawn and analyzed correctly. Another shortcut way that you can do is hydrogen ion can be calculated by subtracting 2 digits after the decimal point of pH from 80. For example, if pH is 7.25, so your hydrogen ion concentration can be done by 80 minus the last 2 digits, 25, which is 55. Okay, so if for pH of 7.25, your hydrogen ion concentration is 55. So this is approximately closer to the hydrogen ion concentration. So this is a consistent ABG. So that will be your first step. Next, you need to know whether it's an alkalosis or an acidosis. How do you know that? Normal pH is 7.35 to 7.45. Anything less than 7.35 is acidosis. Anything more than 7.45 is alkalosis. But please note that an acidosis or alkalosis can be present even if pH is within the normal range. So, you always need to analyze everything together. Next, now you have found out whether it is a acidosis or an alkalosis. Next, you need to know whether the origin of the abnormality is metabolic or respiratory. What is a metabolic component here? Bicarbonate. What is the respiratory component here? Carbon dioxide. Bicarbonate is alkali, carbon dioxide is acid, correct? And we also already discussed why carbon dioxide increase means acidosis, isn't it so? So, putting these two together, if you have a metabolic problem, then the problem is in bicarbonate, or in other words, if there is a bicarbonate problem, then it is a metabolic problem. A low bicarbonate means acidosis. A high bicarbonate means alkalosis. Makes sense, right? Because bicarbonate is alkali. Okay, if alkali increases, it causes alkalosis. If alkali decreases, then it is acidosis, because always acid and alkali are in balance with each other. What about respiratory? The respiratory component in your ABG is carbon dioxide. If carbon dioxide increases, it means acidosis. If it decreases, it means alkalosis. Simple enough. The reason being carbon dioxide is equal to acid because it causes carbonic acid. So, if you put all of these together, whenever you see acidosis, it means pH is less than 7.35. And if the pH is less than 7.35 with a PaCO2 increase, it means it is a respiratory acidosis. Okay. In other words, in a metabolic state, you have acidosis, pH is reduced. I am sorry if you hear background noise, my son is trying to break in the room to stop me from recording. Alright. So, again acidosis means pH is reduced. How do you say metabolic? Metabolic means a bicarbonate decrease. I am sorry for the typo error. Okay. So, bicarbonate decrease. Next, you have alkalosis. Alkalosis means pH is increased. How do you know whether it is metabolic or respiratory? A metabolic cause will have a bicarbonate increase. A respiratory cause will have a carbon dioxide decrease. Okay. So, this is your primary disturbance. You have a reduced pH with carbon dioxide increased, it means it is a acidosis cause being respiratory. If you have a pH reduced, it is acidosis. If bicarbonate is reduced, it means it is a metabolic cause of acidosis. So, now your body is having acidosis, and any normal body will try to compensate for that acidosis, isn't it so? So, you should know how the body is going to compensate and how much the body is going to compensate, and is the compensation enough or not. Usually the respiratory compensation happens fast within minutes to hours, whereas the metabolic compensation happens slow over days, and the compensation varies as a measure of degree of pH change and the acuteness of onset. So, if the primary problem is metabolic, the other system compensates, means the respiratory system compensates. If the primary problem is respiratory, then the metabolic system compensates. So, for example, in a metabolic acidosis, pH is reduced. The reason for acidosis is metabolic, that means bicarbonate should reduce. So, to compensate for reduction in bicarbonate, your PaCO2 will reduce. Why PaCO2 should reduce? See, carbon dioxide is acid. Okay. Only if acid reduces, you will be able to compensate for this acidosis. If this is also increasing, this will add on to the acidosis, correct? So, that is how compensation happens. In a alkalosis, the alkali increases, and if alkali increases, what should be happening in the respiratory system to compensate for this alkali increase? The acid should increase, correct? The acid here is carbon dioxide. Next, in a respiratory acidosis, what is happening? Acidosis, respiratory means carbon dioxide. Carbon dioxide is an acid. carbon dioxide increases resulting in respiratory acidosis. So, if this acid is increasing, to compensate this, alkali should increase. Similarly, in respiratory alkalosis, the carbon dioxide acid component comes down. Okay. So, to compensate that, the alkali component also should come down, resulting in balance between your acid and alkali. Ultimately, that is what your body wants. So, now you know how systems are compensating with each other. Okay. So, in metabolic acidosis, what happens? So, this is metabolic acidosis. You know that in metabolic acidosis, your respiratory system is going to compensate. So, what is the respiratory response that you expect? The response that you expect is PaCO2 should decrease. How much should it decrease? 1.5 times the of bicarbonate plus 8. Okay. So, if this much it is decreasing, then it is the expected change. Or to be very simple, we already saw that your pH last 2 digits, if the acidosis is 15, your PaCO2 that you expect is around 15. Okay. On the other hand, if the PaCO2 you expected it to be 15, okay, but it is 20, it means there is extra 5 carbon dioxide that is there. So, this is acid and this is adding on to the already existing metabolic acidosis. Suppose you want the PaCO2 to be 15, but it is only 10. That means it is 5 less than what you expect. So, there is alkalosis, superimposed alkalosis on top of the existing metabolic acidosis. So, you do not want overcompensation or undercompensation, you want adequate compensation. Okay. So, these are all combined problems, added primary disturbances. What about metabolic alkalosis? Again, in metabolic alkalosis also your carbon dioxide should compensate. Carbon dioxide compensation is calculated based on this formula, 40 plus 0.6 into bicarbonate minus 24. Okay. Again, here as we discussed earlier, if the carbon dioxide that you expected is more than predicted, then it is associated acidosis in the background of alkalosis, and if it is less than predicted, then it is associated respiratory alkalosis in addition to metabolic alkalosis. Now, the patient is having a respiratory acidosis problem. Okay. So, in respiratory acidosis, you want a secondary metabolic response. Always remember, in respiratory primary problem, you always tend to divide it into acute or chronic, okay, by history, or you can also use a calculation that I will be teaching you shortly. Okay. If it is a acute respiratory problem, acute respiratory acidosis, your bicarbonate will rise by 1 millimole per liter for each 10 millimeter PaCO2 rise. If it is chronic, the rise will be 4 for each 10 millimeter of mercury PaCO2 rise. So, 1 and 4. Again, depending upon the amount of compensation, if it is more than predicted, then it is adding to the alkalosis already present, because bicarbonate is an alkali. If it is less than predicted, then there is additional acidosis present. Okay. So, bicarbonate is additional metabolic alkalosis, bicarbonate less is additional metabolic acidosis on top of the previously existing respiratory acidosis. So, how do you know whether it is acute or chronic? As I said, depending upon history, yes, you can do. History wise, if it is less than 3 to 5 days, then you call it as acute. If it is more than 3 to 5 days, you can call it as chronic. Or if you want a more objective method of doing, or patient does not remember, then you can use this formula, hydrogen delta divided by delta PaCO2. Okay. So, when I say delta PaCO2, it means the difference, meaning 40 minus your expected PaCO2 or the existing PaCO2 minus 40, depending upon your acidosis or alkalosis scenario. And if this, whenever you see delta, it is always a difference. So, remember that. Okay. So, when I say delta bicarbonate, it means existing minus your 24 or your 24 minus your existing. When I say delta anion gap, again it means your normal anion gap of 12 or 16 depending upon how you have used the formula, minus your calculated one, or calculated minus your 12 or 16. So delta means difference. If this delta hydrogen ion concentration divided by your delta PaCO2 is less than 0.3, it means chronic. If it's more than 0.8, it is acute. Ammu record pannirukemo. If it's between 0.3 to 0.8, it's acute on chronic. Okay. So less than 0.3 is chronic, more than 0.8 is acute, and 0.3 to 0.8 is acute on chronic respiratory problem. Similarly, for respiratory alkalosis also, there you saw it was 1 and 4 to 5. Here it is 2 and 4. That's the only difference. Okay, rest all same. Rest everything is going to be same. In acute, we expect the bicarbonate to fall by 2 for each 10 rise in PaCO2, fall by 4 in bicarbonate for each 10 rise in PaCO2. Again, if it is more than predicted, bicarbonate more than predicted means there is additional alkalosis. Less than predicted means additional acidosis. So this is combination of all the compensatory methods that I have put together into one single table. I have not put it together, this is from a reference, but still I thought it will be easier for us to revise it once and for all. So metabolic acidosis, the compensation expected is 1.5 into bicarbonate plus 8. Acute respiratory acidosis, you have increase in bicarbonate is delta PaCO2 by 10 plus or minus 3 is the correction factor. Chronic respiratory acidosis, it is 3.5. Here you do not have a factor because it is 1, correct, because we saw 1 and 4, isn't it? So 1 and 4. So instead of 4 they have used 3.5, 4 also can be used. Metabolic alkalosis 40 plus 0.6 into bicarbonate, delta bicarbonate. Acute respiratory alkalosis 2 into delta PaCO2 by 10, because increase or decrease in bicarbonate for every 10 change in your carbon dioxide concentration. Similarly, your bicarbonate change will be 5 for every 10 change in your carbon dioxide concentration. So simply remember 1 and 4, 2 and 5. This is for alkalosis, respiratory alkalosis, and this is for respiratory acidosis. So now you know the primary problem, you know whether it is acidosis or alkalosis, you know whether it is compensated or uncompensated in a ABG strip that is actually correctly done, and now you need to know whether there is just that abnormality that you have calculated or there is additional abnormality. See, now for you to know whether it is single or multiple, there are multiple methods to use to identify it, and here I have used the anion gap method, which is widely followed. Okay. So anion gap is generally applied in the background of a metabolic acidosis, and for you to know whether it's just metabolic acidosis or additional something else is there, you will use delta anion gap and delta bicarbonate. Normal anion gap you calculate by this formula. You can or may not include your potassium. If you include potassium, the values will be 12 plus or minus 4, and if you omit potassium, it is 8 plus or minus 4. And if the anion gap that you have calculated is more than 15, then there is high anion gap metabolic acidosis. If it is less than 12, then it is normal anion gap metabolic acidosis. This is when you add your potassium to your anion gap calculations. So basically, what is anion gap? It's the difference between your cations and anions, or anions and cations if you want to be very specific. Okay. So routinely measured concentration of cations are your sodium and potassium. Anions are chloride and bicarbonate. When the anion gap is greater than that is produced by your albumin, phosphate, sulfates, because that is the reason for your anion gap. These are not normally measured in your regular biochemistry, right? So when you add this and this, you will have some amount of value, no, this 12 or 13 or 15. This difference is because of these weak acids, phosphates, sulfates and lactates. If it is exceeding more than that, then that means some other acid is added on, like for example a lactic acid, or like for example a keto acid in case of DKA. So this results in increased anion gap. Also, another point for you to remember is, in patients with hypoalbuminemia, normal anion gap will be lower than that of 12, because one of the main reasons for anion gap is albumin. Okay, the principal reason for your anion gap is albumin. And the normal anion gap in a patient with hypoalbuminemia is 2.5 milliequivalent per liter, lower for each 1 gram per deciliter decrease in plasma albumin concentration. So, you need to correct your anion gap if your patient has hypoalbuminemia. If anion gap is more than 20 millimole per liter, there is primary metabolic acidosis regardless of your pH or your serum bicarbonate concentration. And another extra point that you can note down taken from Harriet Lane is this: markedly elevated osmolar gap in the setting of an anion gap acidosis is suggestive of intoxication with either methanol or ethylene glycol. Those are just points out of interest. Okay. Next, coming to mixed disorders. So, now you know the anion gap, now you know the bicarbonate. Delta anion gap is whatever anion gap you get minus 12, and delta bicarbonate is 24 minus your calculated bicarbonate. Okay. So, your delta bicarbonate should be equal to delta anion gap if the acidosis is only high anion gap metabolic acidosis. Okay. If bicarbonate is more, then that means there is additional normal anion gap metabolic acidosis. If it is less, then there is additional metabolic alkalosis. One of the common causes for your normal anion gap metabolic acidosis is excessive use of normal saline. Normal saline is personally for me it's a misnomer, because there is nothing normal about normal saline. You actually have supraphysiologic concentrations of chloride in it, which will add on to your or which will cause hyperchloremic metabolic acidosis, which is a normal anion gap metabolic acidosis. Alright, I am digressing. Coming back to this topic. So, now you can do either this, or you can also do a delta ratio. Delta ratio is delta anion gap by delta bicarbonate. See, if you are someone like me who is very poor in divisions especially, then you can use this. This is more easier. If both are equal, then it is only acidosis high anion gap. If it is more, then along with your high anion gap acidosis, you also have additional normal anion gap metabolic acidosis. This is what you might expect in a DKA patient who is being corrected with a normal saline. So, you will have your ketoacidosis improving, but your pH may not improve that much, and you will still have some amount of acidosis. That is because of excessive use of normal saline for maintaining your fluid volume. So, that patient who is corrected with normal saline will have high anion gap acidosis because of the keto acids, plus normal anion gap metabolic acidosis because of your normal saline excessive use. Okay. So, this ratio should be between 1 and 2 if just a high anion gap metabolic acidosis is present. If it is less than 1, then normal anion gap or non-anion gap metabolic acidosis is present along with high anion gap. If it is more than 2, then concurrent metabolic alkalosis is present. So, these are all some of the examples of where you will have mixed disorders. Respiratory acidosis with metabolic acidosis. Suppose a patient with metabolic acidosis is going on to have an apnea or a cardiac arrest or a multi-organ failure, and that person is not able to breathe out properly. Then carbon dioxide accumulation in the background of metabolic acidosis, it will result in a mixed disorder. Respiratory alkalosis with metabolic alkalosis, a cirrhotic patient on diuretic, metabolic alkalosis, respiratory acidosis combination. Severe hypokalemia can cause vomiting, continuous NG suction which is not required. All of these can cause a combination. This is more common in adults with COPD rather than pediatric age group. Okay, so these are all some of the examples. A metabolic acidosis with respiratory alkalosis, I think this is something that we will commonly see in a patient with sepsis, isn't it so? So, same mixed disorders, in the sense you have respiratory acidosis plus metabolic acidosis, or you have respiratory alkalosis plus metabolic alkalosis. Now, both components, both respiratory and metabolic are causing the same problem, right? Till now you did not have much of an issue, because one was an acid, one was an alkali, and both were one was causing the primary problem and the other one was compensating for it somehow. But now you have both acid and alkali causing the same end metabolic abnormality or the respiratory abnormality. So, how do you treat this, or how do you know which came first or which is the primary one? So, if that is the case, you can check for percent difference. The one with the greater percent difference between the two is the dominant one. Here in a case example of pH showing acidosis, bicarbonate is less acidosis, PaCO2 is more, again acidosis. Okay, so all are acidosis, but which is more important or which is the dominant one? So, if you see 24 minus 16 by 24, where 24 is the normal bicarbonate, 16 is your current bicarbonate. If you divide it by the normal value, you get 33%. And PaCO2 difference, 60 is the current one minus 40 is the normal by carbon dioxide concentration. The difference is, or the the percentage is 50%. So, here the respiratory acidosis is the dominant disorder. And as I said, there are multiple ways for you to do it: anion gap, delta ratio, base excess, standard base excess, strong ion difference. You can add along your osmolar gap to provide extra data. You can add along your urinary electrolytes and urinary anion gap to provide you extra data. So, all of them will add on to your understanding of the patient's metabolic abnormality. And you generally do ABG in these conditions, right? You want to know acid base disturbances, oxygenation, ventilation. If you want to assess response to treatment, like in case of a DKA, or if the patient is having a hematological problem like a methemoglobinemia or carboxyhemoglobinemia, then you will do an ABG to assess what is happening. Assess a patient who is on ventilator to see how the oxygenation is going, how is the ventilation is going. So, whenever I say oxygenation, I mean the PaO2. Ventilation, I generally mean a PaCO2. Contraindications are when the Allen's test is negative. Allen's test is where you compress both radial and ulnar artery and try to see if the collateral circulation is intact. There is an Allen's test, there is a modified Allen's test, but basically they test whether the collateral circulation is intact and whether the main arteries are intact. If there is a local infection or thrombus at the site of ABG sampling, or there is an anatomical disruption like a fracture, or the patient is having severe thrombocytopenia. Complications, I am sorry, I am having this, I don't know why this has come like this, but I will just write it down for you guys. So, the complications of an ABG, the common problems, if you are someone who does regular ABG sampling, is bruising in the area where you sampled, bleeding from the area where you sampled unless you apply adequate pressure for adequate time, and pain. Arterial sampling is definitely more painful than venous sampling. Lesser common things are vasospasm and hematoma formation. Rarer ones are air embolism if you have introduced an air bubble, local nerve injury and pseudoaneurysm. What are the common problems or things that you encounter in your practical life setup? You do an ABG to assess a patient, but you see that the patient is improving but ABG is worsening, or vice versa. Patient is worsening but ABG looks like it is improving, because there is a problem in either the pre-analytic phase. Pre-analytic phase is where we draw blood. Okay. Then pre-analytic phase is what is done in lab just before analysis, and analytic phase obviously is done in lab. Okay. So, we will not be discussing the problems in pre and analysis phase. This is what we are concerned about, and this is where most of the errors happen even. So, first confirm whether the test is necessary, and you are asking for the appropriate test, arterial blood gas or a venous blood gas. Then appropriate sample, then appropriate patient. Make sure the patient labeling is proper, you are using the correct barcode, etc. Patient preparation wise, you need to have a calm and prepared patient. Reason being, if the patient is very anxious or the patient is expecting pain and the pain interpreted by the patient is too much, this will result in hyperventilation, so spuriously low carbon dioxide concentration. So, remedy for that is assurance, local anesthesia use before the procedure. Then stabilize the support. Suppose you are changing your ventilator settings and you want to know the effect. Wait for the effect to take place in the patient system. We have changed the ventilator knobs, but does not mean it will immediately reflect in the patient. So, wait for 15 minutes before you sample the patient to look at your oxygenation, ventilation or your acid base status. And always interpret in the background of FiO2 administered. See, for example, suppose a patient with say ARDS is having a PaO2 of 350, assume, okay, so all are theoretical values, and this patient is on, this PaO2 looks fine, right? Normal is 80 to 100, this patient is having 350, that means it's obviously fine. But if you look at the FiO2 is kept at 100%. So for a FiO2 100%, I had actually expected a PaO2 of 500 millimeter of mercury. You get my point. So always interpret your PaO2 in the background of the fraction of inspired oxygen that you are administering. Next, type of blood sample. Always arterial is gold standard. Venous blood especially is not so good if you want to assess your oxygenation. Why? Because already the venous arterial oxygen is extracted and it comes out as venous blood, isn't it so? The arterial oxygen is extracted by tissue by the time the blood reaches the venous circulation. So that is not preferred if you want to do a oxygenation assessment. For you to do a PaO2, always do an ABG. Your pH and PCO2, a central venous sample, is still comparable with arterial blood, and it is well established by research and clinical experience. Okay. Central venous pH is generally very less, in the sense the difference is very negligible, 0.03 to 0.05, and PCO2 is 4 to 5 millimeter of mercury higher. So with this in the background, you can definitely interpret your pH and PCO2 in a venous sample, but never a PO2 in a venous sample. Then the sample collection, it should be collected in an anaerobic method. If you introduce air that is more than 1 to 2% of blood volume, this results in falsely high PaO2 and falsely low PaCO2. So always tap out your air bubbles, cap it tightly, and blood is aspirated directly from the syringe to the analyzer. Try not to waste time. There is always a contention of using whether a glass syringe or a plastic syringe for a ABG assessment. While glass syringe is good, it decreases the oxygen diffusion outside into the environment. Plastic syringes are more easily available, safety and convenience reasons are there. The remedy for this is analyze it immediately within 15 minutes at least. Okay. And another thing to note is plastic syringe, if you put on ice or if it is in a ice cold environment, it actually becomes more permeable to oxygen. So the earlier you analyze, the better, rather than saying I will put it on ice and analyze it 1 hour later. Anticoagulation. Anticoagulation, heparin is the only anticoagulant that is suitable, but try not to use a liquid preparation, because if you use a liquid preparation, it causes dilution of the sample resulting in low PCO2. Too much heparin is a strong acid that results in unnecessary acidosis. The best alternative is electrolyte balanced heparin solutions or heparin preparations that are prepared and kept in your ABG syringe. So it's a commercial ABG syringe which you do not have to do anything, but just collect the sample in a anaerobic way. After collection, do a thorough mixing. Okay. So thorough mixing is repetitive combination of inverting the syringe several times and rolling it through the palm of your hands. So if the mixing time is up to 2 minutes, it's more than enough to ensure homogeneity within the sample. If you do too much of mixing, it causes hemolysis. If there is hemolysis, it causes reduction of pH, PCO2 and PO2. If you do not mix it enough, then the sample clots, then you will not be able to analyze. Timing of analysis. Timing, the more delay you make, the more proportionate changes will happen. Another thing that can happen apart from your decrease in PO2, increase in PCO2 is your glucose problem. Hypoglycemia can ensue. The reason being glycolysis. This glycolysis releases again your PCO2 and consumes PO2, adding to the decrease in PO2 and increase in PCO2. Okay. So to prevent glycolysis, try to keep it at low temperature before analysis as soon as possible. Okay. Always remember, lowering the temperature too much in a plastic syringe has the deleterious effect of increasing oxygen permeability. The transport wise, there is a pneumatic transport system in many corporate hospitals versus a human courier in most of the government hospitals. The earlier you take to the lab, the better it is always. In a pneumatic transport system, pH and PCO2 are generally unaffected. but the effect on PO2 is amplified, especially if the sample has an air bubble in it. So, rather than an increase of 10 millimeter of mercury, it can become 20 millimeter of mercury. So, that is why the sample collection is very important. So, to summarize everything, you have an ABG, you do a pH assessment, you see that it is acidosis. If it is, I am sorry, this is looking very, how to tell, it is not looking very neat, I am sorry, I did not realize it is going to change like this. So, if it is acidosis, see if it is a respiratory acidosis or a metabolic acidosis by looking at your carbon dioxide and bicarbonate concentration. If carbon dioxide increase, it is a respiratory acidosis. Then see if it is acute or chronic depending upon your delta H by delta PCO2 ratio. Then calculate compensation depending upon whether it is acute or chronic. Then adequate or inadequate. If it is metabolic acidosis, then calculate your expected PCO2. See if it is metabolic acidosis only associated with respiratory alkalosis or respiratory acidosis. Then calculate the anion gap. See if it is high anion gap metabolic acidosis. Then look at delta ratio to see if there is additional normal anion gap metabolic acidosis or metabolic alkalosis, depending upon whether the value is less than 1 or more than 2 respectively. Alkalosis, if it is respiratory alkalosis, similar to your respiratory acidosis, acute or chronic, and compensation. If the bicarbonate is more, then it is metabolic alkalosis. You will calculate your expected PaCO2 change, then see if there is additional respiratory acidosis or alkalosis. If it is a mixed disorder and you want to know which is dominant, then calculate the difference. Thank you guys for listening to me patiently. I know that this went on longer than what I had anticipated. These are my references. You can definitely go ahead and refer to these. These are all good resources from which you can learn a lot. So, thank you, bye bye, take care and all the best.